Do we have Dean Russell? Excellent. So Dean wanted to be here in person until yesterday. He was going to be here in person, but unfortunately he's been held back. There's a vote in the Lords going on at the moment with regard to the immigration bill. Dean, welcome. I don't know if you can see us, but we can definitely see you very clearly. And we've got a packed audience still here from the NHS, local authorities, voluntary sector. We've had a great discussion so far. But what we wanted you to do as MP for Watford, particularly importantly, your membership of the Health and Care Select Committee, is talk to us about your vision about the role of digital technology to improve patient service, to reduce administration errors, and to save clinician time. Clinician time, as we know, is a massive pressure at the moment. We've heard a lot today about capacity. Our previous speakers were talking about innovations that will really help physicians find patients who have either been suboptimally managed or not diagnosed at all. So we're going to make the floor yours, and then we're going to take some questions from the floor. And I know that you've put in some killer questions as well. So, Dean, the floor is yours.
Well, thank you so much for inviting me to be there virtually, at least. And there's a certain irony, I think, of the fact I'm doing that to keep it short so that there's more of a Q&A, because I'm conscious when it's a video link, it's harder to judge the room, as it were. So hopefully, if I see any yawns on the screen, I'll try and wrap it up quickly. But I think there's sort of several areas I wanted to talk about, but I thought I'd just give a bit of background to my experience prior to being an MP, actually, because I've been on the Health and Social Care Select Committee, no longer on it now, but as part of that, I also set up or spin off of that, I set up a digital health all-party parliamentary group. But prior to being an MP, I worked in digital for many years. I was a physicist, actually, originally. I've always had quite a lot of passion for technology and new science. And back in the sort of mid-2000s, I was a vice chair of a thing called NHS Health Space, a patient reference panel. And the principle of that in the early mid-2000s was to look at how patient summary care records could be viewed by the patients themselves and the engagement in terms of that. And I've done various different projects with the NHS and Department of Health and from a health perspective over the years. But when I was asked to speak at this today, it occurred to me to look back at an article I wrote back in 2009 for the Health Service Journal. And I think it was called Patients Get Connected or Getting Connected. And it was actually about how does technology or how could technology start to improve the patient experience. And in that, I talked about the two parts, really. One, which was the technology and the rise of technology. It was probably a year or two after the first iPhone had come out. And back then, there was things like the Nintendo Wii, if you remember that, which was they had this sort of health game that was quite popular at the time. I remember there was like a board that you stood on and it took your BMI measurements. And there was lots of really quite cool at that time technology. But zoom on now to 2023, and most people now are used to their phones being able to track their steps, might have an Apple Watch, might have Fitbits, might have all these different tools that measure our health in a way, from a consumer perspective, you could argue, a consumer approach to health, which is that we have all these different types of technologies that track things. But I'm not sure how many clinicians or GPs and people in the health space are able to access that data and use it as part of their engagement with patients. And one of the arguments I put forward in the Health Service Journal article 13, 14 years ago was actually treating patients more as partners in their own health. And how do we make sure that we have an environment where the technology allows that, but also a sort of a change in mindset so that consumers, if you could put it that way, or patients, but from a consumer perspective, are part of that journey. And I think what I've seen over the past few years, especially the past 2-3 years, is this rise in the use of things like AI. We've got far more ways of collecting data now, whether it be your Fitbit or your Apple Watch, your iPhone, or many other ways. But actually, how do you use that data? And I think there's 3 areas that I thought I'd just very, very briefly touch upon. One is in the process of being a patient. Whether it be getting appointments, whether it be following up on appointments, making sure that clinicians aren't spending hours trying to do admin and paperwork, that actually a lot of tools now are coming out which can do that in a very smart and very accurate way. Obviously, there needs to be checks and balances on that. And I think, we've all heard of those stories where a patient, I see it in my casework as an MP, where a patient missed an appointment because the letter came to tell them the appointment was happening, but it came a day after the appointment. And we have these stories where the paper approach of things is very very slow, and the admin side of things can be a real challenge. I remember when I was volunteering during the pandemic, I'd go and volunteer at Watford General Hospital and do whatever they needed me to do. Mainly it was teas and coffees, to be fair, for patients. But actually, I remember volunteering in the maternity office, and I'm sure they won't mind me saying that I saw some of the biggest elastic bands that I've ever seen there, because when you had some of the maternity files, it was folders, sort of massive folders held together. Now they're digitizing a lot of that, and there's a lot of work going into making that data available to everyone much more easily and much more simply. But that's not a criticism. That's just the legacy of how data and information and patient records have evolved over the years. But actually making that digital is going to be essential, both in terms of accuracy, but also in terms of the flow of that data from one clinician to another, but also how the patient engages with that. So one part for me is, I think there's a great opportunity for artificial intelligence to help sort of manage that flow, make sure that, if a patient has an appointment, what's the flow of that? What's the follow-up? How does that flow through to future appointments? But I think there's another aspect to it, which is really core to what I've been talking about for many years. And I'll be very happy to be challenged on this if you disagree, but about how we put the patient at the center of everything and have what I call a single patient view. Now, in my work years ago in marketing and communications and in digital, a lot of the big companies, the Googles and the Amazons, will have what they call a single customer view, and they'll have one place, and then whatever product they're pushing or promoting, whatever data they're collecting, that there's one person at the center of that. And I think what I saw over the years outside of being an MP within the NHS and within healthcare is often a patient will interact with one part of the NHS or one part of healthcare related to the issue they have at that time, not necessarily holistically on their whole, about their whole self. And so the example I give, and it's probably a terrible example, so anyone who's an expert in arthritis here will probably tell me I'm totally wrong on this, but the example I use for my layman's mindset is that if somebody had onset arthritis, for example, and they're in the early stages, and if there's no cure in sight, and they know that over the next 10, 20, 30 years, it's likely to get a lot worse and affect their mobility, then actually at the moment, they might have individual appointments around that. But in reality, that's going to affect their lives in many ways. The lack of mobility over 5, 10, 20, 30 years may affect their mental health. It might affect their ability to work. It might mean that they need additional support for social care. It might affect their ability to do the job that they were doing, and therefore what support is there for them in that way. So actually, when you look at the impact of a physical health condition, it may have many other areas that will affect their lives. And I think, and I'd gladly be challenged on this, I'm not sure how much at the moment the system looks at the holistic person and says, actually, how will this ailment in one area affect them in their other areas, the mental health, mobility, their work, their social care, what sort of budgets are needed now that they've had that diagnosis over the course of their lifetime. What impact might that have on their family? And obviously this is sort of blue sky hopes, but actually perhaps with artificial intelligence and with the use of technology and the use of better diagnostics, but also putting the patient at the center and having a patient-centric view, then perhaps we can start to look at how we can help with other areas in their lives off the back of that, but also look at how we can budget for that better, look at how they can be passed through the system better, look at what other potential predictive areas they might need support on. And then that comes to the third point, which is about how we look at predictive use of data and also use data to help with other areas as well. So one of the areas I often think about is in terms of donors. So obviously, sadly, when somebody passes away, they might donate their organs, and they might be able to help perhaps 3 or 4 people if they're if lucky from their organ donations, which could save someone else's life or multiple lives. But actually, if we think about that from a data perspective, what we learned during the pandemic with the vaccine was the ability to do those clinical trials en masse very, very quickly and use that data meant that we could quite quickly find a cure for something that we perhaps wouldn't have been able to in any other way. And I would argue that perhaps we need to look to a model of what I call data donors. So saying to people who are taking particular drugs or medications, people who've got certain ailments, could they actively donate their data? Could they share what's on their Apple Watch? Could they share the side effects? Could they share data related to what they're going through to be used in a live mass clinical trial? Of course, from a anonymized or pseudo-anonymized, but the idea of using that data in live in a way that's actually ongoing, that could be used potentially not just to save 2 or 3 people, but potentially help cure cancer or help find the cures for rare diseases. And my take is that actually, if we can use data in a smart way like that and get people to be bought into it and be engaged, then that's got to be a good thing, because that will help use data for the individual to help society, but do it in a safe way. Now, I'll be honest, I'm quite skeptical and quite critical of AI. I'm very worried about the impacts on society, deep fakes, the impact of bad actors wanting to use it around harming democracy. There's lots of areas that I'm very concerned about, but I do think there's a really strong place for, with the right safeguards, for it to be used in healthcare to help save lives, but also help that patient experience. So I'm conscious, I don't think I've seen anyone yawn yet, but I don't want to overstay my welcome with my speech, and I'm keen to take some questions. But just to summarize, I think there's an opportunity for data and technology to help with the flow of the admin process, which hopefully will take time, give time back to clinicians. I think there's a second part, which is about how we use technology. For example, in Watford General, we have a fantastic team there who do work around around virtual wards, for example, and robotics, and opportunities to use that within the actual process of supporting the patient and having a single patient view. And then finally, about how we use data from individuals who donate that to help predict things for the future and perhaps be part of live clinical trials to help cure some of the most difficult challenges we face at the moment. So I'll leave it there. I hopefully haven't gone too far off tangent, but thank you so much.
So we've been talking, Dean, this afternoon a lot because it is a #1 priority for NHS and local authority people in the room today about health inequalities. And, you know, smartwatches and ability to use the NHS app and all the rest of it. What about the elephant in the room, the digitally excluded?
I can give you 3 points on that. So that's something that back in 2001, I wrote articles about the digital divide. So one of the areas I did a lot of work on in my early career was about online accessibility. I actually worked with the RNIB on the world's first online accessible game. So I'm very aware of the concerns there. I think my take, though, is that you can't. So the second point I was going to make, was that I think with regards to that, you have to work to the premise that those who want to who have got the ability to do that, create those opportunities, but rather than say, let's drive everybody towards the digital solution, say, well, actually, we can create more time then in real life for people who aren't using those technologies, who aren't able to use them. So I've had situations in my own constituency where GP surgeries have gone fully online, so they won't even take phone calls for appointments.
We've lost you, Dean. So those Westminster walls. No. Do like the House of Commons curtains. Has anybody noticed those? Have we got questions from the floor if we do get Dean back? We got any? Can we, while we're just waiting to get this back, rather than have a sort of embarrassing silence, should we have a wee chat about some of the points that Dean covered there? I was interested in his thoughts about the predictive use of data and data donors, for research. When we did the COVID infection survey, we had 600,000 UK citizens in that. Just shy of 400,000 of them consented to take part in future research. Sadly, now that's gone back into UK Health Security Agency. It's been mothballed. 400,000 people who'd signed up to take part in future research. Kate Bingham had the same problem with the vaccines registry, which Dean was alluding to there. They hit a roadblock with the lawyers saying, oh, they haven't consented properly. They had 500,000 people. And now we're going around with Our Future Health trying to recruit people to take part in that. We've got the Grail Gallieri study going on. The pilot's gone really well. That needs to expand out to 10 million people. So I think it's all very well, people on high saying, yeah, we want to do this, we want to have data donors. I'm just interested in the audience's view on that. And I wrote down when he said that, the quote from Habib, trust is a new determinant of health. So just some thoughts on that. Adam?
It was exactly to that point. I mean, there's still no answer around the secondary use of patient-level records for health, for population health purposes. So there's barriers there. But I wear a With Things device. I stand or sit here as a cardiology dream for a trial. But, you know, and with Thing, I just ticked a box. They've got all of my data. Google Health have got all of my data. Yet there's no facility for me to say, yes, IQVIA, I'd gladly donate my healthcare records for you to use them for purposes that are for the greater good. And so it's exactly to that point. That was the question I was going to ask. You know, why is it so difficult when it's so easy for me to passively agree to hand my data to people who will use it appropriately or inappropriately, but harvest it anyway and charge me for doing so. Yeah. So yeah, it was the same point really.
Points building on that, and that trust as a determinant of health and the use of people's health data for either research or just actually to improve their health. I mean, Umar, you know, you talked about the kind of work that you did to make people feel comfortable. Any thoughts learning on that? Because it's massive and it's not going to go away. And we now have the move to secure data environments for research, which is being rolled out across the country, which hopefully is a good step forward and will get us around the major issues that we have with NHS Digital, who are about to kick the UK off the top of the league table through their unwillingness to allow appropriate access for data for research and all their shenanigans. So, yeah.
Yes, we came at the problem in a slightly different way, which is not secondary use of data, but sort of primary care delivery. And so I think that for our patients, we're not necessarily helping every single patient because they may not have a condition yet, but ultimately that is what it's going to lead to. So there's a direct benefit first. We started with the direct benefit first, and then there's the kind of future predictive benefits. And that's sort of, I think, how you build trust. And I think also it's helpful to try and get the providers involved. So again, because we're making life easy for the GPs, there's more engagement from the GPs in trying to do that communication piece, because I do think you need to involve the clinicians as well as part of it. That's a trusted resource that patients, they rely on. That's what they trust.
For sure. Thank you, Umar. No?
So, I don't know whether you can hear me yet.
Yes, we can hear you. Hurrah. Can you hear us?
Oh, brilliant.
Okay. So we got into that digitally excluded bit, and we actually had a wee chat in the audience.
I could hear, thankfully, so I could hear what was said. I think my point, if I may, just very briefly, was that I think at the moment there still seems to be this bit that if you can get people to use digital, then you should push everyone to do it. And my take is that if you can save time by getting people to use digital, that should then free up time to have more face-to-face support for people who haven't, and perhaps help coach them and get them on board. But I think that the trouble with digital since, like I say, 23 years ago when I first started working in this as a career, is that it's often talked about in a binary way. You either use it or this idea that we need to shift everybody to use one way of working. And the challenge with that is that you then exclude huge swathes of people, including people who just don't want to do it. It doesn't necessarily mean they haven't got the technology, but perhaps they don't feel comfortable. And I think that's that's something we have to think about, how to bring people along, but also always have space for those who can't or don't want to use that technology.
100%. Safety nets. Dr. Leggett.
Thank you. Interestingly, digital inclusion can actually help those who are digitally excluded. If you think about Google, for example, Google can predict outbreaks of contagious disease several days, if not weeks, before patients present themselves, because everyone is Googling their symptoms. So Google knows the outbreaks. And actually, we in general practice know that too. We can see patterns. People present with headaches. We know what's going around our community. If you were to tap into primary care data, you would see that in real time. You would see the evolution of diseases across the UK. The thing that's prohibiting us, though, is legislation. We can't share data. Yeah. We want to share data with the majority of us, and it would transform healthcare in the UK. How can we drop those barriers? How can legislation help us?
Talking of legislation, unfortunately, I've got to go and help vote for some because the division bell's just gone. But I think what I would say, if it's helpful to know, is that, because I will have to run, what is helpful, hopefully, to know is that there is a lot of talk at the moment. I've spoken into the Secretary of State about things like my data donor concept and so on. And we've got the Global AI Summit coming later this year as well, which is going to help, I think, look how that technology can be used. But also looking at how, because I agree around GDPR and all of those things, there's some real challenges there, which are legislatively in place as barriers, but also they should also be there to help smooth the way and make things safer. But I will say goodbye now, and my apologies, but thank you to everyone for being patient with me. Bye-bye. And thank you for inviting me.
Thank you.
Thank you. Take care. Bye. Bye.
Thank you very much.